Welcome to Your Anxious Child, 5-Minute Solutions, a podcast dedicated to providing practical advice and support for parents of anxious children. This advice is informational in nature and not a substitute for a consultation with a licensed mental health professional. And now, here's your host, Dr. Edward Plimpton.
Welcome back to Your Anxious Child, 5-Minute Solutions, and interviews with experts. Did you know that 1 in 5 children, by some estimates, experience chronic pain? To my mind, this has been a rather kind of neglected kind of issue for children. Fortunately, today, we have 2 experts on the topic, Penina Zillberberg and Paulina Soble, who have co-authored with Daniella Deutsch the Pain Reprocessing Workbook for Teens, Rewire Your Brain to Find Relief from Chronic Pain. So, thank you, Paulina and Penina, for joining us today to talk about your book, which I actually am rather excited about, especially since I work in a pediatric practice. So perhaps you could just kind of tell us a little bit more about yourselves before we launch into talking about your book.
Sure. So thank you for having us here. My name is Paulina Soble. I am a licensed clinical social worker, and I really specialize in the treatment of chronic neuroplastic pain, which neuroplastic pain is really brain-generated pain that doesn't come from an underlying structural issue or disease, which is what we're going to be talking about today. So I have trained a number of practitioners in this model. I have a training center where we work with medical providers and mental health providers and coaches and physical therapists and all types of practitioners who treat patients with chronic pain. And I also treat patients myself. I have a private practice called Well Body Psychotherapy, where we see adolescents and teens and adults who struggle with chronic pain and other chronic symptoms. And we really treat them primarily with this modality called Pain Reprocessing Therapy, which is an evidence-based treatment for chronic pain. And we'll be getting into that more today.
And I am Penina Zilberberg. I am a licensed clinical psychologist specializing in children, adolescents, and families, particularly with child and adolescent anxiety and emotion regulation and chronic pain. And I work with children and adolescents individually, but also with parents, because obviously when we're working with children, parents are a huge part of the equation with regards to understanding and treatment of what we're looking at. And I do parent training as well. So for me, this is kind of like what I do has made its way from child anxiety and chronic pain in children and adolescents.
Well, I'm very excited to kind of hear about your approach. So, tell us a little bit about the pain reprocessing kind of therapy, and perhaps you use the term neuroplastic. And it would be great if you could just tell us a little bit about pain and the type of pain that's the focus of your treatment approach.
Yeah, sure. So we use the term neuroplastic pain, but there are actually there's a lot of different terminology that people may have heard that describe the same thing. It is a descriptor for primary pain, where pain is the primary presenting problem. It's not that there's some structural injury or tissue damage or disease process that is causing the pain, and the pain is then secondary to that structural issue. It means that the pain is the primary problem. All pain comes from the brain, but with neuroplastic pain, neural pathways in the brain have learned and remembered pain, and the pain might persist long after an injury has healed, or if there was no injury at all. Or really, in its pure form, it means that there's nothing underlying in your body that is off. that is causing you to experience pain. It's that your brain is interpreting danger where there is none, and it's sending a false alarm. So our treatment helps you reappraise and understand what is really going on in your body so that you can start sending a more neutral or safer message that your body is okay. You don't need this danger signal to be going off if you do truly have neuroplastic pain and there's no reason for that alarm.
There is a very compelling example that the two of you use in your book about a London construction worker. And I wonder if you could just recount that very compelling kind of description.
So the story is about this construction worker who jumped down on a nail and sees it go through his boot and automatically starts feeling tremendous pain and screaming and is rushed to the emergency room in all that pain. And when they finally reach the emergency room and the doctors remove the boot to look at it, they see that the nail has not pierced his foot at all. It went right between his toes, causing no damage at all. And yet his brain processed it as pain. And why is that? It's because classically we associate physical damage with pain and pain with physical damage. So right away, when we see something, our brain automatically, as Paulina just explained in the definition of neuroplastic pain, we tend to associate pain with physical damage. But the other piece of it is that the brain creates pain as a protective measure. And so we'll talk, I'm sure, soon about acute pain versus chronic pain. But right away, when the brain senses danger, it sends a measure it sends signals of pain. And so when we have a physical injury, that is actually protective because it's keeping us off that foot, for example, the damaged limb. But in chronic pain, in neuroplastic pain, it's sensing danger and sending those real signals of pain, despite the fact that the body is completely safe.
Mm-hmm. And really the compelling, I think, point of that construction worker story is that the perception of damage alone can cause your brain to generate pain. Even if your body is healthy, but you perceive or interpret that there is something dangerous, then that danger signal, that warning sign of pain is going to go off in an effort to protect you. So it's the power of belief.
Right. A considerable power, we might note.
Mm-hmm.
How do you begin to make the distinction that what we're dealing with is not pain from a physical injury, at some point, but rather it's more pain that's generated from an oversensitized brain? How do we begin to kind of make that kind of distinction that that's what we're dealing with? I mean, you mentioned briefly, a timeline of 3 months or more.
Yeah, and that timeline is really the difference between acute and chronic pain. But I think what you're asking is more the assessment piece of chronic of symptoms or pain, whether they've been there for less than 3 months or more. So we want to understand how this pain is presenting. Is it behaving and presenting in a way that structural pain would, as in it's very consistent? Let's say a certain trigger ignites your pain. Maybe you have back pain, and every time you sit, your back pain comes on. But if sometimes you sit and your back pain isn't there, then that makes us question, okay, well, why is it usually there, but sometimes not? Does the pain travel around your body? Does it vary in intensity? Is it worse when you're stressed out and kind of lighter and calmer when you're in a more calm or positive state? So we want to assess the pain and understand, is this coming purely from the brain, or is there a physical component here? And we do this in order to gather evidence. We have the patient gather their own evidence that their body really is safe. because they can see that, oh, my pain really doesn't behave the way that it would if I truly were injured or there was truly a disease process happening because there's so many inconsistencies.
So for the adolescent sort of taking this approach, one of their first tasks is to kind of learn about how pain works and the kind of distinction between the qualities of physical injury pain versus pain that now is not being generated from a physical injury, but rather more, shall we say, brain generated?
I think that's 100% true. So I think it's starting with the education rather than, trying to convince them, oh, yeah, this is. It's more as Paulina was explaining that it's kind of like an exploratory process where they are gathering evidence and then we're looking at it together and we're saying, um, okay, so this is how structural pain works. And this is how structural pain doesn't work. So we're looking at it together so that they're becoming curious and informed and educated about it before we even necessarily get to telling them, oh, yes, this is what it is. We kind of want to do it together and have them try to see that for themselves because the way that we've tended to think about pain is that obviously it's physical. So when someone has told them, oh, it didn't appear on a test, they say, oh, no, maybe they're wrong. Maybe they missed something. Obviously, it has to be that something is wrong. Well, yeah, something is, but we're looking at it from the wrong angle. And I think part of the process of them seeing that, I guess a good way that I like to think about it is that say that you go to your doctor and he tests you for, you've been sick for a couple of weeks, whether you're a child or an adult, it's kind of the same thing. And he says it's a virus. This medication isn't going to help. And they say, well, I'm feeling really sick. Nothing else is going away. Can you give me this antibacterial medication? And the doctor relents and says, okay, and he gives it to you, and then you don't get better from it. So that in and of itself is another clue that like, okay, if that didn't work, if the medication didn't work, then maybe I'm treating it the wrong way.
I think you're also kind of suggesting kind of something else because there, with a lot of medical issues, there can be some diagnostic uncertainty. So that, for example, I mean, our diagnostic tests are imperfect, and an example I'm particularly, kind of familiar are the role of kind of infections in kind of creating neuropsychiatric problems such as pandas. But
Mhm.
the diagnosis of something like pandas is far from a kind of a precise, kind of art. Um, but I think that what you're saying is that look, you've had, in so many words, where we have a variety of tests that we have done, and they have nothing has kind of come out that's kind of revealed anything. If we want to make progress, I think that we should give this other avenue a real good kind of exploration because that's an area where we can kind of really begin to kind of make some progress. And it may be that something turns up later on, but here's an area where we can kind of see by the way in which the symptoms are presenting that we should go down this lane. D- What what are your thoughts about that approach or thought?
Hmm. Yeah, I think that, well, all pain comes from the brain. The brain generates pain. And there's different avenues in the way that it does this. And so we can have bottom up processing from our body up to our brain. And so there might be some physical condition going on that is causing the pain. But there's also top down processing that amplifies the level, the intensity of the symptom that the person is experiencing. And so that is maybe something that's unrelated to the pain, but in the patient's life that is causing fear or stress or having them exist in a high alert state or creating hypervigilance or preoccupation or anxiety. All of this can amplify the level of pain that someone experiences. So even if they have a diagnosis, this treatment might be very helpful in reducing the level of pain that they feel. So we can assess maybe a person does have a case of mixed pain where there is some diagnosis and they do need to work with medical providers alongside a therapist or alongside their pain reprocessing provider. but we can certainly still help them in so many cases. Even if we really would say, okay, of course that's physical, but the fact that you're so stressed at work and you're fighting with your spouse and you don't know how to take care of yourself is making your experience of pain a lot more difficult, a lot more intense.
I thought you also made kind of an interesting point that if you notice that things like providing attention to your pain or being occupied with something else takes away the pain, that is an indication that there's an area where you can kind of exert some potential control in the
Mhm.
future that you found. Whereas true, other types of pain would be very stubbornly resistant to any diversion of your attention one way or the other. Is that fair to say?
Yes, I mean, I would say so. I think that if you are existing in a positive emotional state or you're engaged in something that you really enjoy and you don't notice the pain, you're not focused on it, you can almost assume that it's not there at all. If it's not hurting you right now, okay, then it's not there. And that might not be conscious in the moment, but it shows us the power of the brain and attention and preoccupation. And if your pain increases just by looking at it, but not, doing any physical manipulation, not putting pressure on or some sort of movement, then we know that this is a brain problem, or at least partially, that your brain has influence over how you're going to feel. And I hope that can be empowering to patients, that they do have some control. They do have an ability to heal themselves. They don't have to live with this pain forever.
And I think that that's such an important positive way of looking at this diagnosis. It's such a positive diagnosis because if it was just physical, then there would be only one way of treating that. But the fact that there like this incredible power of the brain to be able to amplify pain or decrease pain is a powerful thing. And thinking of this treatment is something that is very often a very positive thing for people who recognize that this is what's going on. But obviously, there's a process to where they're first ready to hear it and to see it and to be open to this as an opportunity for treatment and coming out of this pain.
So, this is an approach that has been developed with adults, and to my, and you have now are working to kind of translate this into for teenagers, adolescents. Are there any kind of special considerations or thoughts that you had with regard to that? You know, you made a very important point that we don't want someone to become identified with their pain. And adolescence is a time of identity formation, and just kind of curious about your thoughts about approaching this topic with this age group.
Absolutely. So, I mean, that's such an important question. There are a number of factors that we have to look at because adolescents and pre-adolescents are not just miniature adults, and so we have to look at what's different. So, what we look at what's different is developmental stage in terms of brain development. That's one thing. So we see a very big difference, and we need to really understand that what we're looking at that's different between children and adults. Um, so, for example, it's a time where there is amplified threat sensitivity, particularly when it comes to social situations, peer rejection, not being good enough, feeling like they're disappointing someone, not meeting expectations, etc. So that's one thing. And at the same time, that there's a more heightened stress response, the part of their brain that regulates their ability to like kind of like look at this, take perspective, that part is still maturing. The prefrontal cortex is a part that's still maturing. So we have amplified threat sensitivity along with not as much caught up regulation part of their brain. So we have that, and we have to really, really look at that because that makes it kind of like a risk window for them for this amplification of the stress pain system. So that's one thing that's different that we can talk about specifically. Another thing that's different is the parent factor. And another thing that's different is identity formation. So, as you mentioned, identity formation is a very, very important part that that adolescents are supposed to be developing, risk-taking a little bit, interacting with friends and new opportunities, whether it's academic, social, sports. And when they are avoiding and they're staying home, they're not having that opportunity to develop a sense of who they are, what they're good at, what they're not good at, how much they can push themselves. They're just avoiding and therefore seeing themselves, unfortunately, as fragile. And the longer that they are in that kind of like pain sick persona, um, as a way that they see their own self, the fear is that they don't have the opportunity to figure out who they can be. So that's second, and we can certainly talk about that more. And the third piece that's extremely important with kids that you don't really have with adults is the parent piece, because parents are co-regulators for kids on their nervous system and their ability to calm it. They're constantly asking themselves, am I safe? Am I fragile? Am I capable? And they really look to their parents' nervous system and how their parents react to that. And so a very big piece here is working with parents, first assessing their own beliefs about pain, about how the child in general is acting, how they should be acting with regards to pain, how they act around pain, working with the protective instincts of parents, good parents, right? We're always like naturally like we're supposed to protect our kids and keep them safe. And this is counterintuitive here because it's the exact opposite. The more we protect them and shield them, the more they get the message of, I'm not safe. I can't do this. I have to stay home. And so we have to work with parents at the beginning. Also, one more important belief is that's communicated to the kids nonverbally and to the adolescents nonverbally is the parents' belief and faith in this as a treatment, in this as a possibility for coming out of pain. So the very first thing that we have to do is to I usually actually I always bring parents in first and work with them to help them understand it so that we're on the same page first, because you're going to get nowhere with an adolescent if the parent doesn't really totally believe in it, or if there's two parents and one does and one doesn't. So you really have to do a lot of work preliminarily just working with the parents. So those are three pieces that are very crucial and are very different than in working with adults alone.
Um, what an eloquent, description of this too. Um, I'd love to have you kind of just elaborate perhaps on the issue of kind of a identity formation and how you can kind of help the teenager or adolescent disentangle their experience from who they are, or just kind of your thoughts about how to help them with that.
So it's an excellent question and it's so important. The first thing is that just like adults, kids also have the sense of that, like, I'm not ready to go back. I have to wait until I'm fully recovered. That's similar between adults and adolescents. But the difference is that with adolescents, as I said, parents tend to want to protect their kids. It's a natural instinct, right? I know with my own kids, Paulina now has her own baby. So I think that you can really relate to the fact that we just want to fix things for them. We want them to be safe and comfortable. But with regards to this in particular, what we have to do, like being a good parent of an infant or a toddler or a young child in protection, is very different than what we have to do here. Because being a good parent here, we have to really reframe for parents and really work with them to help to understand that being a good parent here and being helpful with regard to a pre-adolescent or an adolescent is helping them to see that you're okay. You're not going to do damage to yourself by moving or by going to school. And so a very big piece of this here is to encourage the adolescent and to work with the parents to encourage their adolescent to re-engage in their life. Because what is going to help them is if you think about what's going on with neuroplastic pain, it's triggered by fear. And so the longer that they're staying away from school, away from their friends, away from all the things that were important to them and made them think about who they are as, I'm good at sports, I'm good at academics, I have friends, people like me, I'm good at figuring things out, all these types of things, now it's kind of like stunted. So the first thing that we have to do is to help explain that And before we do send them back, we have to make sure that they have enough skills, but not that they're free of pain, because part of them freeing the pain is reducing the fear. Part of reducing the fear is re-engaging them in their life with a proper support system so that they begin to see, oh, I did it. Like, we send them in with a support network that we create together with them so that they own it, not that they're being told what to do, so that they have someone they can turn to and they can gradually make their way back in. And as that happens, feel good about what went right. Like, I did this and I was okay. And that's extremely important here.
I'm just gathering my thoughts for 1 second.
Sure.
Um, so, let's kind of talk a little bit about how they get there. You talk about becoming a pain detective, um, and finding out how your pain works. Um, and one of the kind of powerhouse, tools you have is this idea of somatic tracking. And I think it would be kind of helpful if you could kind of describe what somatic tracking is and why it's such a helpful tool in this situation.
Sure. So, first, I'll say that pain reprocessing therapy is an exposure therapy, really. So, we need to be exposed to our pain in order to have the opportunity to work with it and to react and respond differently than we normally would. Usually, when we are in pain all the time, we react with some sort of fear or dread or hopelessness or whatever it might be because the pain hurts and we don't want it to be there. And maybe we don't know what else to do to make it go away, or we don't believe that it ever will go away. And the goal with somatic tracking is not necessarily to make the pain go away, but to send a different message when the pain comes on. So, there's three components to somatic tracking. The first is mindfulness. And so you're really just being mindful in the present moment without a desired outcome or specific goal about the pain. So just feel the sensation in your body and become a little bit more comfortable or more familiar with it. Even if you don't like it, even if it's uncomfortable, you just want to be mindful about its its a presentation, location, intensity, any quality of the sensation. And you want to do this with what we call safety reappraisal. If we look at the pain as though it's dangerous, it's going to hurt us, then we reinforce the fear message. So instead, we want to reinforce a safety message, which we can find authentic safety messaging from using the client's evidence list that they've built before we ever do these somatic techniques, right? So I know that my pain is better on the weekends. I know that that the pain is temporary, that this flare is temporary. Maybe I know that the pain moves around my body. So, what evidence do we have that your body is actually safe and your brain is at play here? And so, looking at the sensation alone is not going to damage you. It's not going to make your recovery worse or make your recovery harder. And hopefully, we can also pay attention with this kind of air of lightness and curiosity and ease and just learning about the sensation rather than examining it with scrutiny and intensity the way you might if you're studying for a test, right? Um, that also sends a lighter, safe message to your brain, whereas intensity sends a more dangerous message, right? The danger signal is being amplified there. So somatic tracking is a somatic exercise, but we're usually just talking the patient through this, leading them through this meditation of sorts that incorporates this positive affect induction and this safety reappraisal when we're looking at the pain.
So, one of the things it seems to me that you're doing there is really teaching um, people that the transitory nature of feelings, that feelings kind of come and go. So, as you kind of experience this sensation, you are kind of learning and seeing that actually does not last forever, and that it has a trajectory, and you're not stuck with it forever.
Mm-hmm.
Um,
Yeah,
It's also
and just
sure. Go ahead.
I was just going to say, you're just kind of gathering data. When I just look at my pain, what happens? Does it change? Does it get more intense? Does it ease off? Does it lighten up? Does it move around my body? Does just noticing it change my experience of it? And if it does, then you have some good evidence that your brain has a big role here because you're not physically manipulating your body.
And I think the first step of it is, as Paulina described, is being curious about it and not feeling like you can't handle something that's uncomfortable. This is something that we do with anxiety also, right? Exposure with anxiety. And it's a similar concept where, as Paulina explained, you're kind of being curious together and trying to like look at, oh, what is this like? And once you're doing that, you're able to recognize, like, wow, my brain is incredible at being able to do that rather than, oh my God, I can't handle this. Oh my God, I got rid of the pain, which creates more intensity. So we're just trying to do the opposite. We're trying to say, okay, we can look at this. Um, and yeah, as you said, feelings are transitory. But even before that happened, we're okay to look at this. We can describe it. We can be curious about it. We can just kind of observe it.
Yeah, I believe, I thought that you also added a sort of perhaps a cautionary note in terms of being mindful about the level of pain that's being experienced at the moment. And that, at the higher levels of pain, if we have um, a, a scale of 1 to 10, things that are in the 8, 9, 10 range, that we might need to kind of do slightly different approach compared to when the pain's at a lower level. I wonder if you could
Right.
just kind of talk about that a bit.
Yeah, so I like to give this example of, let's say that you are taking a trip to the zoo and you're walking around and you're seeing these different animals, but they're behind the bars of their cage. So you can mindfully watch them because you know that you're safe, right? They're in their cage, they're not going to hurt you. And so let's say you get to the lion's enclosure. You can be mindful about the lion's movement and curiously watching the way they move. But if the lion were to break out of the cage, you could no longer mindfully watch the way it moves with a level of safety and curiosity because you would be frantically running away. You would be in real danger and there would be no mindfulness or safety about it. So that is kind of a good analogy when it comes to the level of pain. If you're in a 10 out of 10 level of pain, your brain cannot mindfully and safely and curiously notice the pain from a calm state. So oftentimes, if you try to do somatic tracking when the pain is just excruciating, you're not going to have that sort of positive corrective experience that we're looking for. You're more so going to re-traumatize your brain and send the signal, this pain really is dangerous and I better get away from it, because when I look at it, it just gets worse and it's unbearable to me. And we don't want you to have that experience. So the pain is an opportunity to practice, but you're more likely to be able to, effectively use mindfulness and use safety reappraisal when the pain is manageable. So let's say it's at a 5, 4, 5, or 6 level out of 10. When it gets up really high, it hurts. It's difficult to say, oh, I'm okay. This pain is safe when it's really that intense. So we don't want to push people too far. And when the pain is really intense, there's other tools you can use, like just grounding, or breathing, or noticing a pleasant sensation in your body, right? So you can do somatic tracking with a sensation in your body that authentically feels safe and easy. And you can look at it without too much effort, right? And you can also establish, okay, I have this really painful part of my body, but my whole body is not in danger. The bottom of my feet don't hurt. They're safe, or my neck, I can move my neck around without any pain or whatever it is for you. And sometimes that's going to be more beneficial than trying to force yourself to do somatic tracking at that time.
I love that analogy, by the way, Paulina. I think that that's so great and helpful. And I think that that's what this is really about. The book is really a roadmap for helping people to understand not just the techniques and the way that we explain them, but also how and when to use them, how and when to use each one.
Yeah. Uh, um, your in the high intensity stuff. You refer to it, Paulina. It's a grounding technique of, rather than kind of focusing inside, it's time to focus outside using your external senses of kind of noticing outside of your body, more predominantly than focusing inside, which is going to amplify things, which is also similar to what we do with kind of panic as well.
Hmm.
Right.
Uh, so I would be kind of curious about your advice about how to effectively use this workbook and kind of tips for that. Um, how should um, people go about doing it? Should it just be the private business of the teenager? Should it be a joint effort? How can we get to, what's been your experience in terms of how to um, get the most mileage, out of all of these great ideas?
So I think that
But
this is meant for practitioners, for parents, and for teens. For practitioners who are already a little bit familiar or haven't been familiar and want to familiarize themselves with a technique, actually, when I started using these techniques, was I was seeing more of anxiety, and then I was seeing more of pain related to the anxiety, and not even to specific anxiety, but just really neuroplastic. And so, having more practitioners become familiar with something that's out there, whereas previously pain, as I said, was perceived more as it must be body damage, to help more practitioners, um, doctors, and therapists become familiar with that as a possibility, as a technique for treatment. And then for parents and teens, this was made specifically for teens and even the pre-adolescent period, with simple analogies and examples and very engaging illustrations to help them really be able to relate to it, to what's going on with them, because it's not enough for kids to just be told, this is a theory that works for you, right? Because they have been told that many times by the time that they're coming in to our office. Um, so it's not enough to say, okay, I'm confident with this. So between the book and the way that we use this and engage them in therapy at the beginning is to help them to really understand it and believe it and be curious about it as another way of handling this when nothing else has worked before, helping them to understand why maybe it is that nothing helped before and why this could work before. So I think it's really important to engage all those parents, the teens themselves, as well as the practitioners. So parents and teens can read it together, or teens can, read it themselves. We have like separate parts of the book that are written specifically, like a forward for parents to help them understand beforehand. And we kept that as like a little bit separate than what the teens are looking at, because we also don't want teens to think like that this is something that they're being told they have to do. We want to engage them in their interest in understanding in it, using the kind of like not just the illustrations that are so engaging that help them to relate and understand it, with a little bit of comics in there, um, but also like worksheets and activities for them to think about it a little bit, where I've seen young kids picking this themselves up on their own and being very, very engaged and curious about it as something that is a positive way of doing it, as opposed to another thing that's being dumped on them.
I kind of like your use of optical illusions as a
Mm.
way of illustrating how the brain can kind of make mistakes. And, in the book, you have two kind of classic optical illusions.
Mhm.
And I kind of like them as a way of kind of just making the kind of point that, your brain can kind of, can get tricked and
Right.
then can have false alarms and the like.
Mhm. And, it's like you don't want it to be minimizing, to be told, "Oh, you're not seeing it, you're not feeling it." But that's why we thought that, we feel like in practice that those illusions are a good way, especially with the skeptical teen, although really for anyone, to really understand, wait, like, you're telling me that it's all in my head, no, it isn't. It's really there. But our body reacts to things that we're seeing that are not always exactly the way that we see them. They're perceived by our body in a certain way, by our brain in a certain way, and our senses in a certain way, and then our body reacts accordingly. And illustrations, these optical illusions are a really good way for them to actually concretely see that.
Yeah, I totally agree. I totally agree. Um, there's so much to your book. I feel like I should ask, what we have, what important things we've not touched upon or we've kind of overlooked before we stop. And I just kind of want to make sure we haven't there's not a glaring omission here in terms of what we've kind of covered. Um, um, One thing I would just kind of mention is I think the process of somatic tracking is one of those things that is kind of simple and complex at the same time. I think it's often hard for people to be aware of their sensations and being aware of how intense they are. And I think that parents, correspondingly, often struggle with gauging um, the nervous system of their children. And I think it comes up in kind of a variety of different ways. The most simple example would be um, in infancy with the unfortunate debate about kind of sleep training with children, with some people saying, well, you should just kind of let them cry it out. An approach which totally disregards the kind of nervous system of what the young infant is capable of doing. Um, I think we often struggle with kind of getting a good, estimation about what is somebody really up for. And we can kind of either overestimate it or underestimate it. And I think, that's one of the kind of challenges I think also in dealing with pain in terms of from a parent's perspective, in terms of how much of a challenge, but the individual, also struggles with that in terms of, you know, for example, when you go exercise, often for some of us, getting exercise seems like the worst idea that you could think about. And,
Mhm.
totally alien. And then 15, 20 minutes into it, oh, that's my body. And hey, this actually feels good. So
So I think that when we talk about kids and adolescents, what we want is the skills to match the emotions. So
mhm,
they've got all these emotions and challenges, and we want to make sure that they have the skills. Um, the way that we think about it, and I think we even put this in the book, is the way that we like to do it is, we can think about it when it comes to anxiety. It's the same thing. You can throw a kid into a pool and they're going to learn to swim eventually, but with much trauma that they're not yet capable of. But the way that is more preferred that we like to do things is more gradually. They step in it slowly, and then we give them the water wings and they stay near the side, and then they make their way in. Saying to a child, no, you can't swim, it's too scary, you could drown, that is on the parent end something that would not be very helpful, and that would not be being a very good parent. So we teach them to do it gradually, and it's the same thing here. And so we give them the skills, and it's part of what we have in the book that Paulina was explaining earlier about different techniques for different levels of anxiety, because we understand that it's not one size fits all. Here you show up on day one, and here's the techniques, and this could work, and let's go. It really has to be a sense of that their skills are built up a little bit, and we take it a little bit at their pace in terms of their understanding and their engagement in it and their readiness for it. And here we are as cheerleaders in the book, really guiding them along or guiding parents along, which is so important, and guiding therapists along as well to understand the process of how to help them build their skills a little bit, but really understand, are they there yet? Are they capable yet? Not just are we confident in this treatment, but are they there with us?
Right.
And
Okay.
I think an important point too is that children believe that they are as capable as their parent makes them feel,
Mhm.
right? You are as capable as your parent thinks you are, right? And that is how children get their messaging. So if the parent can, be a cheerleader and say, you can do this, and even if that's a gradual exposure and not being thrown in the deep end, that is going to give the child so much confidence, and ability. And again, if they believe they can do it, then they can. And if they believe that they can't, then that's going to really hold them back. So I think that the parent message plays a really important point there, to not enable the child to just avoid everything because they don't want to see them in pain. That's going to prolong the chronic pain that they're experiencing and really prolong the suffering. But also, exactly as Penina mentioned, we can take it in baby steps. So it's not, all trauma at the beginning. We can slowly build up confidence. And I think that can be important for the parents.
And it's so huge because, that's why I meet with parents at the beginning to first assess their beliefs and make them feel heard and see what they're experiencing and have them be engaged in the process, but not just at the beginning, but all along throughout treatment. Um, they need to be involved also to see, like, are they retreating back to their fear? Because fear in a parent's nervous system is going to definitely be communicated, not intentionally, but it's going to be read by the nervous system of their child. And absolutely, what Paulina said is something that I see all the time, which is that kids believe they're capable of what their parents believe they are capable of. So now we're getting into their level of fear, and fear promotes chronic pain. So we want to really decrease the fear, and a very big, very crucial, not like a side part of therapy, but really a crucial part of therapy is having the parents be on board and assessing any concerns or anxieties that they have about encouraging their child to get back into their life as much as possible.
And in a parallel, fashion, I'm thinking about how important it is, the working relationship between the parent and the physician, be- because the parent obviously needs to have some confidence and some faith in the pediatrician or the specialist that they're dealing with in order to, you know, to approach their child with kind of confidence, or if nothing else, Botox parenting.
Yeah, 100%.
Yeah. So we're about out of time. So where can people learn more about pain reprocessing therapy and um
Sure.
you-
So yeah, so for pain reprocessing therapy, if you look that up, you will find everything. Our
okay.
website is just painreprocessingtherapy.com. Our Instagram is at Pain Reprocessing Therapy. That's where you can find a lot of information on neuroplastic pain, studies, evidence, data, as well as how to treat this, how to become trained in it, and how to receive treatment as a pain patient yourself.
Telehealth an option for any of this?
Yes, definitely.
Yeah, and they can access the Pain Reprocessing Therapy Center for telehealth and just get in touch over there. And I can be reached at penina.zilberberg@gmail.com. I'm also on Instagram as Dr. PZ Parenting. Um, and I just want to say one, just kind of like one takeaway message, if I had to say, is that one of the things that we're looking at in teens and preteens is why this is not just why this works so well, but also why this is such a crucial period for intervention, because it's such a window of opportunity, because the brains are so highly plastic in adolescence, because of identity formation and how important that is. And because we really want to teach kids from a younger age how to address themselves with self-compassion, pay attention to their feelings, set appropriate boundaries. Because if you look at what you see a lot of the time in chronic pain is a history of perhaps not having been able to do so. And so if we can start kids earlier, not just on the current situation of the pain they're currently in, which is tremendously important, but also to be able to not ignore it, to be able to take care of their own self so that the brain doesn't have to send pain signals in order to do that. And I think that the earlier we can get in there to help children and adolescents with that, the better off they will be.
So out of this, potentially unfortunate experience are the seeds of actually some greater resilience.
Yeah.
Yeah. Great. Well, thank you so much for taking the time out of your busy schedules to kind of talk with me today. Um, and I'm certainly kind of very excited about the approach that you guys have developed.
It's been great
Well, thank you
chatting.
for
Thank
having
you.
us.
Thank you for listening to Your Anxious Child. Please leave us a rating and review in iTunes to help us get the word out. If you'd like to learn more and find additional resources, visit us at edwardplimpton.com.